Say goodbye to monotonous books and say hello to colorful interconnected mind maps. In this series, we will quickly help you revise important concepts with the help of mind maps, which you can access later using our app. In this video, we will revise important topics of benign lesions of the oral cavity. Let's begin with squamous papilloma. Squamous papilloma is a benign growth characterized by numerous small finger-like projections that create a roughened, verrucous or cauliflower-like surface. It is commonly associated with human papillomavirus types 6 and 11, which have low virulence and infectivity rates. Clinical features of squamous papilloma include a well-circumscribed pedunculated tumor, occasionally sessile, that is painless and typically white in color, but can also appear pink. It is commonly found on the tongue, lips, buccal mucosa, gingiva, and palate in the oral cavity. Histologically, squamous papilloma shows many long, thin, finger-like projections extending above the mucosal surface. There is a papillary pattern with the proliferation of spinous cells. Coeliocytes, which are HPV-altered epithelial cells with perinuclear clear spaces and nuclear pycnosis, may be found in the superficial layers of the epithelium. The treatment for squamous papilloma involves excision, which includes removing the entire lesion, including the base of the mucosa into which the pedicle or stalk of the growth inserts. This procedure is done to prevent recurrence. The next tumor is the Veruca vulgaris, also known as a common wart. It is a benign growth caused by the human papillomavirus, specifically types 2, 4, 6, and 40. It leads to focal hyperplasia of the stratified squamous epithelium. These warts are contagious and can spread to other parts of a person's skin or mucous membranes through autoinoculation. In oral mucosa, Veruca vulgaris is relatively infrequent but extremely common on the skin, especially in children. The oral lesions are usually found on the vermilion border, labial mucosa, or anterior tongue. Clinically, a Veruca vulgaris appears as a painless papule or nodule with papillary projections or a rough pebbly surface. Histopathology shows proliferation of hyperkeratotic stratified squamous epithelium with finger-like projections and connective tissue cores. Elongated rete ridges converge toward the center of the lesion, producing a cupping effect. The granular cell layer is prominent and abundant coeliocytes are found in the superficial spinous layer. The treatment for skin verrucae include topical salicylic acid, topical lactic acid, or liquid nitrogen cryotherapy. On the other hand, oral lesions are usually surgically excised to prevent recurrence and eliminate the wart from the oral mucosa. The next lesion, keratocanthoma, is also known as self-healing carcinoma or verrucoma. It is a relatively common low-grade malignancy that originates in the pilosebaceous glands. Clinically and pathologically, keratocanthoma resembles squamous cell carcinoma. Various etiological factors contribute to the development of keratocanthoma, including exposure to sunlight, chemical carcinogens, trauma, infection with specific human papillomavirus types 9, 11, 13, 16, 18, 24, 25, 33, 37, and 57, genetic factors, and immunocompromised status. Keratocanthomas are more common in men and typically occur on sun-exposed areas of the skin. They are present as dome-shaped nodules with a smooth, shiny surface and a central craterform ulceration or keratin plug that may project like a horn. Histologically, the most characteristic feature of keratocanthoma is found at the margins. It is that the normal adjacent epithelium is elevated towards the central portion of the crater, and then there is an abrupt change in the normal epithelium as the hyperplastic acanthoic epithelium is reached. The surface is covered by a thickened layer of parakeratin or orthokeratin with central plugging. Treatment of keratocanthoma involves close monitoring as some lesions undergo spontaneous regression. If the lesion is persistent or growing, surgical excision is recommended to ensure complete removal. Another very important lesion we will discuss is the oral nevi. They are benign proliferations of nevus cells that can occur in either the epithelium or connective tissue and are considered hamartomas or developmental malformations. It is termed a garment nevi when the size exceeds 10 cm. Oral nevi can be found in various locations within the oral cavity, with the most common sites being the hard palate and buccal mucosa. Other common locations include the vermilion border of the lip and the labial mucosa. There are different types of nevi including spitz nevis, halo nevis, blue nevis, intradermal nevis, junctional nevis, and compound nevis. Spitz nevis is characterized by spindle cell and or epithelioid cell proliferation. It appears as a solitary dome-shaped pink to reddish-brown papule and is commonly observed in children. The next type, halo nevis, is a melanocytic nevis with a pale hypopigmented border or halo surrounding it. The halo is a result of nevis cell destruction by the immune system. The third type is a blue nevis, which is a benign proliferation of dermal melanocytes, usually located deep within the subepithelial connective tissue. There are different subtypes including common blue nevis and cellular blue nevis. It appears blue due to a phenomenon called Tyndall effect, which you can see in this section of the mind map. Moving on, the intradermal nevis or the common mole consists of neval cells located entirely in the dermis. The nevis cells are separated from the overlying epithelium by a well-defined band of connective tissue. The junctional nevis is another type of nevis and is limited to the basal layer of the epithelium. There is no zone of demarcation, and the nevis cells contact and blend into the surface epithelium. This nevis type may show the aptoprofunct or dropping off effect, as the thin overlying epithelium shows cell crossing into the junction and growing down into the connective tissue. Lastly, the compound nevis contains nevis cells in both the epidermis and dermis, exhibiting features of both the junctional and intradermal nevi. Treatment of oral nevi is generally recommended if they occur in areas that are irritated or causing discomfort. It is essential to differentiate nevi from other pigmented lesions, and a thorough evaluation by a dermatologist or oral surgeon is necessary to determine the appropriate course of action. Some other concepts in relation to benign tumors of the oral cavity include squamous acanthoma, Cowden syndrome, BK mole syndrome, and Hex disease. You can see some details in relation to these in the other key points section of our mind map. With this, we come to the end of this video. Hopefully, we have helped you revise some important points quickly. Now, with these refreshed concepts, you can head over to the MCQ section of our app and solve some questions related to this topic. Happy learning!